Thank you all for coming. My name is Cammerman. I'm an anaesthetist at Charlie's and am a regional anaesthetist, having completed my fellowship at Charlie's a few years ago. I'd like to begin by acknowledging the traditional custodians of the land on which we meet today. I'd also like to pay my respects to ancestors and elders past and present. So thank you all for coming to the biannual WA Regional Anaesthesia Journal Club meeting. It's getting towards the end of the year, lots of summer holidays planned, so nice to get a bit of education done before everyone switches off their minds and goes elsewhere. It's great to see this good turnout tonight. Nice mix of consultants and trainees. We usually get a bit of APS nurses and APS teams coming as well, but I think that there weren't as many able to come tonight, but hopefully the next meeting they'll be able to come. Without our sponsors, tonight wouldn't have been able to happen either. So thank you to Catherine Rice from ICU Medical, to Kate and Kiali from Duke Medical, to Michael O'Hara from Sonosite, and to Palapal from Medtronic, who I don't think that they could be here today. But we very much appreciate your support of our meetings and look forward to seeing you at all of our future events. Some quick housekeeping. There's a QR code just at the front as soon as you guys walk into the auditorium. Please sign in and log your attendance. You'll get a certificate at the end. That means that we can just keep an attendance log of who has come this evening. Toilet's just out the back and to the right. Feel free to stick around afterwards to continue having a bit of food and drinks and a mingle and a catch-up. Unfortunately, one of the speakers tonight, Dr. Joel Krause, is quite unwell with a case of the man flu, so he isn't able to come. So if you all look under your seats, there's a red sticker, and the person who finds that actually gets to do the fourth talk tonight. No. We're just with the three speakers, three fantastic speakers lined up tonight. Ed's going to talk to us about gastric ultrasound and its utility. We will also be doing a live demonstration of gastric ultrasound. And then the next two speakers will be talking about peripheral nerve complications and a quality improvement project of the stop before you block process, improving that process. We'll aim for all the speakers just to follow on one after the other. We'll just try and keep the questions until the very end. So hold them for afterwards. And now that the wheels are in motion for this Journal Club meeting, I think this is the fourth one that we've run in the last 2 years. And we'll continue to endeavour to run 2 per year. We've got some great topics lined up for next May. Talking about nerve stimulators, interscaling catheters versus single shots, amongst many other interesting topics. If anyone has any further ideas for topics that they would like to hear about or that they would like to present themselves, if they found the red dot underneath their chair, then please let me know at the end of the night. All the talks will be recorded and will be put onto the WASORA website, which you guys can also have access to, and there will be a WASORA newsletter with a summary of each of the talks as well. Our first speaker is Dr. Ed Halvey. Ed is a consultant anaesthetist at Charlie's with a keen interest in regional anaesthesia, and by virtue of his talk has a keen interest in gastric ultrasound. He originally comes from the UK, completing his medical degree at the University College London. Welcome, Ed.
Great, thank you very much. So, gastric ultrasound. So, in general, most of us assume that if you fast for 6 hours for food and 2 hours for liquids, then you can be assured that the stomach is empty and plan your anaesthetic accordingly. However, then came along the GLP-1 receptor agonists, which somewhat threw that rule into disarray due to their ability to substantially delay gastric emptying. Case reports then followed that suggested stomachs were full of solid matter despite following fasting guidelines, and even extended fasting times of 24 hours didn't help matters. But then again, there was some conflicting advice that say that we should continue that, we should stop it for a week. We're getting there's no international consensus that I can tell so far. What to do about these things. ANSCA recommend anyone taking these things within 4 weeks preceding anaesthesia should be considered to have a full stomach. Even GI symptoms like feeling full or nausea, they are associated with increased risk, but their absence doesn't help you out. It doesn't exclude significant gastric content. So it's a tricky area. And I guess wouldn't it be nice to have a look at the stomach and see if it is full in itself, which brings us, of course, to gastric ultrasound, which can be used for this risk stratification. I suppose if you haven't got it, alternatively, you can postpone surgery by 4 weeks. That'll make you very popular. And then after those 4 weeks, presume there's restoration of gastric transit times. When they're off, they're ozempic. Or you can consent them to aspiration and do an RSI. So it's a tricky one to deal with. So what can gastric ultrasound tell us? So it can alert us to the presence of contents within the stomach, and it gives us that opportunity to adjust our anaesthetic plan accordingly, tube, no tube, RSI, no RSI. But what exactly does it tell us? So it can tell us if the stomach is empty, it can tell us if there's significant amount of fluid, or if there's solid matter within the stomach. And how do we get this information? So we use a 3-step approach. The first one is to use the correct probe, and really I think the only correct probe is a curvilinear probe, because that's the one that gives you the depth required and the sort of the wider footprint that you need to get the full image and the correct sort of plane that you need. So you get your curvilinear probe, which we've got tonight, and then you need to identify the gastric antrum. And it's actually fairly straightforward. You need that correct plane, which is between the liver and the great vessels. So you'll pop the probe on in a sagittal orientation underneath the xiphoid process with the probe marker pointing towards the head, starting the midline. And 90% of the time, you get your image straight away. And it's quick and easy and all as well. Sometimes you may need to shift left or right a bit just to get the right sort of cut and plane through. But then the gastric antrum is then easily identified. So the correct plane that I'm mentioning is this plane here. So it's between the liver and the aorta. These are the two things that you want to line up. So you'll see liver and aorta. Once you see those two things, you'll generally see a structure in the middle. Looks somewhat like a bullseye. Sometimes it looks like a flat tire, sometimes like a bullseye when it's empty. And that will be the gastric antrum. But the key is to get correct image acquisition is that plane, the liver and the aorta. Okay. So you'll see the aorta in the long axis. It looks like a long tube. It's pulsatile, obviously, where it should be. You may also see the IVC next to aorta, and then underneath that you'll see the bony vertebral bodies. You may see the superior mesenteric artery, the SMA, and the pancreas, but that's not that important. The SMA is quite tortuous and curvy, and trying to get that lined up is very difficult. You will, of course, see the inferior edge of the liver, and then you'll pick up the antrum, which will have this sort of characteristic appearance. Can be a bullseye, or it can be, like in this image here, a bit like a flattened tire. Now the key is, how do you know it's the antrum? Well, it's got this 5 different layer appearance, with each layer having a different echogeneity. The serosa on the very edge is bright, and then you'll have this very thick, dark layer, the muscularis propria, and that's really the key that separates it from things like the colon or the duodenum. This very thick layer around it, and you'll classically, we've got lots of slides, you'll see this thick hypoechoic layer all the way around, and that's what sets it apart. Good. Okay, so key to scanning, get the right cut between the great vessels and the lip of the liver, and that hollow viscus is going to be the antrum. So you've got your right probe, you've got your right plane with the liver and the aorta, and then you're going to do a qualitative assessment. There's 4 patterns that you'll see. The first one is empty, and you'll have this thick antral wall that's like kind of corrugated and all contracted and empty and lovely. And decision making then is simple. It's you're in the supine position, you don't see any fluid, that's empty. You're not quite done yet because you just want to make sure it's completely empty, so you'll tilt them on the side or sit them bolt upright, and gravity will help move fluid down. If they've had, beg your pardon, I've gone way too far. Yeah, good. So if there's fluid in the lateral position, that doesn't mean there's loads of fluid. You have baseline secretions that correlates with about 100 mils or less, and that's consistent with baseline gastric secretions. I'll come on to the grading system shortly. And then I've got an image here. So in this one, we've got good image acquisition. We've got the liver and the aorta, you can see. And then you've got this like a flattened football or bicycle tire rather than that classic sort of bullseye target. And the gastric antrum appears flat. The anterior and posterior walls are juxtaposed. And you can see a little bit of fluid in there, and that's consistent really with baseline secretions. So you could call this like a grade 0. Oops, too far. The next pattern you'll see is this clear fluid pattern, and that's easy to recognize. This time, because there's clear fluid, the antrum is thinner and it's stretched and it's not contracted. The contents look dark, like an area that's been injected with local anesthetic. If they've recently drank fluids or they've had like carbonated drinks, you'll see bubbles within it and it'll have this starry appearance. Decision making for this, if you see clear fluid in the supine position, so you're not even got gravity helping you out, then there's probably a reasonable amount of fluid in there. And we would class that as a grade 2 or a high risk of aspiration of fluid. That said, if you did scan someone like this who's had like carb loading drinks, if you wait about 12 minutes or so, that's the half time for clear fluids to clear the stomach, it may reduce in volume. So if they've recently had like a clear fluid and you see that in the supine position, if you send them back to the holding bay for a quarter of an hour, rescan them, then it probably would have cleared at that point. So a bit more about that grading system that I've mentioned a few times. So you can see the table in the top right here. Hopefully you can see it. It's well validated and reproducible enough to help you make a decision. But essentially, if fluid's seen in the supine position, then this is considered clinically significant volume and the stomach should be treated as full. Right, so the next pattern is solids. So this is what early solids look like. And because we swallow a lot of air while we're eating and swallowing, that air creates this sort of frosted glass appearance just around here. And that's in the superficial part of the antrum, and it's all artifact below that. All you can see is the frosted glass, and that's full, and that's all you can say. It looks grossly abnormal, contrasting with the sort of bullseye appearance of earlier empty antrums. And your decision-making wise, you're full. It's full stomach, you're done. You may see this late phase. So as the air gets dispersed within the churning movements of the stomach, the solid chunks of food begin to be digested. The food becomes chyme. So chyme is this like part liquid, part solid, thick, semi-fluid mass of partially digested food and digestive secretions. Kind of looks like maybe like a soup or a smoothie you could consider. And you begin to see this as the air interface blocking the ultrasound beams is removed. The antrum will remain expanded, like the clear fluid pattern, but this time you'll see like a non-black, grey type smoothie consistency in there. All right, so, yeah, good. Sorry, that's too far. So I've done a table to try and simplify it, summarise everything. But essentially, you're going to see when the antrum's small and contracted, you have an empty stomach. Whereas expanded, that suggests the presence of fluids or solids. If the expanded contents is black, that would suggest fluid, and if it's non-black, that would suggest a process of chyme or a solid solution within the antrum. Whereas if you see black with small bubbles, that'll be more clear fluid. So that's a key thing, is the antrum big or small, and then what's inside. So in terms of doing all this scanning, we'll do some scanning in a second. Can I do it? So it's definitely something we can learn. If you're not experienced with ultrasound, it's thought to take about 33 supervised scans to get a 95% accuracy, which is pretty quick. If you're good with regional, you can take that down to about 9 practice scans. So that's what's been posted as the minimum level of training. There is online courses available, but it's still fairly new. There's a QR code there if you want to do the course. Of course, there are limits to gastric ultrasound, and it is inconclusive in around 3% of subjects despite optimum conditions. And there is a risk of misinterpretation of the hollow viscus. So here you've got the liver, you can't see the aorta, so straight away you say it's not the correct plane. But this structure here, you could perhaps convince yourself that's the antrum, and you've got the walls, juxtapodes, but that is of course the kidney. And this frosted glassed appearance could be the antrum. So there is potential for danger, I suppose. There's other things that they could look like, a bit like the gallbladder with gallstones. And there's another image with the gallbladder with a gallstone in it. Again, this is not the correct plane because you're not seeing the aorta, the lip of the liver, ditto here, but there's a risk of misinterpretation. Pregnant patients or patients who've had gastric surgery, again, it wouldn't be accurate, or a very large hiatus hernia where the contents of the stomach might be located within the herniated portion of the stomach. So, final thoughts on gastric ultrasound. This chap's very pro-gastric ultrasound. He forms an essential part of his particular practice. And he's very much said that, this is something that we should be using. There is a lot of skeptics out there, which is good and healthy. And they say, healthy patients with empty stomachs can still aspirate bile, and we shouldn't be postponing surgery or making airway decisions based on POCUS without any evidence. We still do SIP to send. These are all reasonable arguments. I suppose the counter arguments would be, what's the hassle factor? It's easy to learn, takes 30 seconds to get the data, learning curve's quick. You don't need to go on a week-long course. I think it does change management. You can think, well, I'm going to do a spinal. Should I do deep sedation? So you can influence your decision-making. You could plan for RSI, but then see a completely empty antrum, so perhaps maybe downgrade it just to a standard sequence induction. So I think it's, useful, and we'll do some scanning now, if that's all right, Mike. Yeah. And hopefully this is working. Turn this on. Hello. Right, so we've got Mike with a selection of drinks. Yeah. Right then. Get on the pump. Okay, so again, we'll just get our probe, go in the midline, so in the correct position, and hopefully we should have our gastric antrum. I'll just decrease the depth a bit more. Right then, okay, so we've got, first thing I would do is find the lip of the liver, and then I've got the aorta at the bottom. Okay, so that's the first thing I'll do, and I've got my correct plane. Then I'm looking for a hollow viscus and there's the SMA just coming in there as well. I'm looking for a structure that's just got a really black layer around it. I don't know if you can see that just above the SMA. Can I convince you there? It's this teeny tiny, and it's kind of more like a deflated balloon this time. Be able to take a drink of apple juice, but now hopefully when we have a little drink, we should see this crop up real nice. And there you can see it coming in to view now. Have another drink there. I think he's dehydrated. He's got a big stomach.
That's your fault.
Yeah, sorry. So still quite empty, and gobble it up. Right, do you want to have your beer next?
I've got two stomachs.
Yeah.
Beer?
Yeah, beer, go for it. All right, we're starting to get some. Right then, so you can sort of starting to see some of it coming there. So down the hatch. Right, so now the gastric antrum's expanded significantly. You see that structure there? It's way, way bigger. Before it was teeny tiny, but it's starting to fill up now. And there it is starting. You can see the fluid coming in there now? Yeah? And there's like these little speckles of air in there now as well. That's consistent with some fluid. Yeah, so it's significantly bigger. So it's bigger and more dilated. In fact, it's way bigger now, isn't it? So it's starting to fill up and relax. Good. Do you want to have...
Sorry, here, bird.
Yeah. Right, good. And that's it getting... Right, do you want to eat some grub? Sure. Let's see some food now. Right, so that's way bigger now, that gastric antrum. The walls of the gastric antrum are much smaller. So now when we start eating food, he'll start swallowing air, and we'll start to see some, like that frosted glass appearance. You can see that now there, some of the fluid. Yeah, so that's expanding now nicely. Yeah, and the man doesn't swallow air. Yeah. Oh, there we go. It's a bit coming through. So, good. Yeah. Pretty cool, huh? Mm. Yeah. Look at that. It's so there's no air in there whatsoever. It's impressive. You're a swallowing master. Yeah. Oh, there we go. There's a bit of air now coming through. Do you want to have the rest of that?
Yeah, sure.
Will I drink down the hatch?
I'll try and swallow some air.
Yeah, yeah. Cool. That's it, full there. So we'll probably see eventually you'll start seeing some air coming through.
Yeah, nice.
Yeah.
Looks like there's more air in there.
Yeah. So yeah, it's definitely full. Cool. Cool. Thank you very much.
No worries, mate.
Right. Thank you.
Thanks, Ed, and thanks, Michael, for sculling your beer.
Maybe we do one every talk.
Our second speaker is Anat Greentall. Anat is the former Regional Anaesthesia Fellow at Royal Perth and is an overseas fellow from Israel, hailing from Rambam Hospital in Haifa. Anat will be speaking about complications post-peripheral nerve blocks. Please welcome Anat.
Hello, my name is Anat, and like Adam said, I'm just finished up a regional fellowship at Royal Perth Fellowship. It's not as a cool topic, and there's no real-time ultrasound, but something that I kind of I felt like was a bit missing as part of the fellowship was talking about complications, because as regional fellows, I think I was excited to block. I wanted to block all the time. I was like, I'll go find people to block. Who can I block? Can I block this person? Can I block your patient? But really, I didn't want to forget about the tenet that we learned in medical school, which was first do no harm. So when I was thinking of, I was asked to speak originally at the previous journal club meeting, and it didn't happen for a couple of reasons, but so I was thinking of what I would talk about, and I guess I was interested in this topic, so I started reading about it, and If you look through the literature, there's like an explosion of literature, but who knows, is any of it, it's not like it's not consistent, let's put it that way, and I didn't know what to believe, what is right, and if you talk to the consultants at whatever hospital you're working at, everyone will tell you they're certain that if you do this and this and this, then there won't be any complications, or the complications are like this, but you talk to someone else, they'll tell you something very different, but they're certain that they're right also. So I was trying to see what was in the literature, and I think one of the things that I felt also in general in anesthetics, it's a service-based medical specialty, and we don't follow up a lot of our patients. So the orthopedic surgeons, they're the ones that see the patients later on, so we might see them for a day or two on the acute pain service, but not often afterwards. And so I was kind of felt a little bit uncomfortable if there was, something going on that I had done that I didn't know about, things like that. So I started reading the literature. And a lot of the literature and a lot of the big studies, they're really, really old, in the 90s, or older than the 90s. Things have changed quite a bit since then. Ultrasound is routinely used now. It wasn't routinely used then, but on the other hand, we do a lot more regional anesthesia than we used to do. So I'm just going to go. So first of all, this, in general, I'm not talking about LAST or systemic complications. I'm specifically talking about the nerve injury, peripheral nerve injury. How can we injure the nerves? So we can injure them with direct needle trauma, with the neurotoxicity. We know that local anesthetics are toxic to the nerve tissue themselves. If we injure the blood vessels, whether it's a large blood vessel and cause a hematoma, or if pressure will reduce the blood supply to the nerves, that can injure the nerves. There's also injury that happens to the nerves in the surgery, and we all like to say that it's the surgeon's fault, or the surgeon likes to say it's our fault. We always are looking for fault. The tourniquet can injure the nerves, and then there's intraoperative and postoperative factors that can injure the nerves, like swelling and pressure. And then there is an interesting entity that I think, at least I knew less about until I started reading up on it, was the inflammatory neuropathy that can happen after surgery. So originally, by originally I mean in 1942, and then in 1951, Seddon and then Sunderland originally classified nerve injury. Seddon divided it into three, which was neuropraxia, which almost always has a favorable prognosis, axonotmesis, and then neurotmesis, which has a much poorer prognosis. Sunderland, if you read his article, it's kind of interesting. He's telling Seddon that medical students don't know Greek anymore, so you have to say it in English and not in Greek. And he divided it into the levels of damage. If it was just myelin, it was also the loss of axonal continuity, but the endoneurium was intact, or then if the endoneurium was injured, and then if the perineurium was injured, or, and the worst, it would be complete nerve transection. So how can we reduce the risk? Kind of doing the end at the beginning, but we want to avoid intraneural injection, so we use the shorter bevels rather than the hypodermic needles to lower the chances of having an intravesicular injection, using lower pressure injection. Do any of us measure pressure anymore when we inject? I've never ever done it. Using the lowest effective dose and concentration, because we know that the local anesthetics are neurotoxic, but then, if we're lowering the dose and the concentration, then we're getting a shorter effect. So it's kind of plus or minus there. And then, of course, the ultimate question, does ultrasound aid us in any of this? Because as far as I know, no one in the literature has been able to show that ultrasound guided blocks lowers the rate of specifically peripheral nerve injury. There has been some studies that show that it can lower the risk of of an IV injection, but not that it lowers, but we're all convinced that it does. Oh, sorry, I'm going. Okay, so if we're looking at the literature, it's a bit dry, and like I said, there's tons of it, and it's very difficult to do search, but so originally there's the ASA closed claims database. I'm sure you all know that the ASA closed claims database is not only regional anesthesia, it's any claims in anesthesia that were paid out with or without, like, it doesn't matter if there was fault or not. And then obviously then there was literature about it. So in 2011, they were looking at claims that had been from 1990 onwards. And the problem is that there is no denominator. So we know how many claims there were, but we don't know how many blocks were performed. So it gives us nothing about the incidence of it. What it does show us is of the closed claims, which were more common. So most of them were interscalene and then auxiliary. Some less were IV regional anesthesia, and then much, much less were femoral, ankle, supraclavicular, and others. And none of them were associated with ultrasound-guided blocks. So there must not be any peripheral nerve injury with ultrasound-guided blocks. Obviously not, I'm being facetious, but anyways, it's interesting, but it can't show us very much about what, and as we do more and more blocks, then the chances, if there's some sort of incidence, obviously we'll see more of them. So a big review in 2007 in anesthesia and analgesia looked at studies between 1995 and 2005. There were 32 studies that they included in this review. A lot of them were they were looking at regional anesthesia in general, including neuraxial. So there was still a lot more literature about neuraxial blockade. And then of the studies that were about peripheral nerve blockade, most of them were about upper limb. The two biggest ones that were, I think that this is where we always say 0.4 per 10,000. I was always very interested, where did that number come from? So it comes from some of the earliest is the studies by Roy, which are very large studies. And that's the incidence that he found in two different studies that he did, 3.8 in 10,000 or 2.7 in 10,000. And if we're looking at just the transient neurological deficits that we can see that most of them do go away, then the highest risk was for interscaling blocks, which I think classically we were taught that interscaling blocks have the highest risk of nerve damage. But again, and what I found to be systematic in all of the literature is who decided and how did they decide if the nerve damage was because of a block or because of other things. And it's very interesting. You'll see as I get to the end, I'll get to the orthopedic literature, and their numbers are pretty different than our literature. So again, more reviews. This is Michael Barrington's review. This is done in Australia and New Zealand. So this was a big study that there used to be a database, I don't know what happened to that, but that all the blocks were inputted at least for a certain amount of years. And then they, the hospitals that participated in this, they followed up the patients either at 7 to 10 days or at 6 weeks. So there was heterogeneity dependent on the center. And then again, and here there's a lot more ultrasound use already. 2/3 of the blocks were done with ultrasound. 30 patients were referred for neurological assessment, so that's about 0.5%. But then out of those, only 3 are categorized as peripheral nerve injury due to peripheral nerve block. They don't really say, I mean, I've just shown a little bit of one of the tables in their study, but if you're looking at patient number 15, who had an axillary block for finger amputation, and then he had ulnar neuritis, and they claimed it was unrelated to peripheral nerve block. Well, they didn't tell me in their study where was the ulnar neuritis, but you know, when I do an axillary block, I definitely block the ulnar nerve. So it could be caused by a block, but they said it's not caused by the block. So a lot of the literature, I mean, again, don't want to look for blame, but if we're looking for that number of what is the incidence, then I wasn't convinced in anything that I read, I'll be quite honest. Just again, more studies that I saw. This study in the Journal of Neurosurgery of Anesthesiology was interesting because they, again, you can see that in the reviews, obviously, that some of the studies are repeating themselves. The big studies by Oroy are here too, and they showed the incidence. And then if you look at the final 3, you see that the incidence is significantly higher, right? Because these patients had direct follow-up versus the other were chart reviews or the anesthesiologist reports. So that's another thing. How are we looking at these patients? When are we looking at them or talking to them? Are we going and asking them, do you have any numbness, tingling, anything like that? Or are we just seeing what was reported? Because the incidence is very, very different. In regional anesthesia and pain medicine in 2020, there was a retrospective review of 19,000 patients at Toronto Western Hospital, which is really big, lots of blocks, but really only 3,000 of the patients, well, that's a lot of patients, but it's definitely not all of the 19,000 were contacted. And again, they had transient symptoms of 14.4%. And again, I wasn't quite convinced by their decision of which was peripheral nerve injury because of blocks or which was because of something else. And this is the newest and biggest review that I was able to see. And again, what was nice about this review is that they looked at peripheral block, they called it nerve dysfunction, at lots of time periods. And then we can see really that the incidence goes, like most of the patients, the nerve dysfunction resolves, but not all. And then if you look at the orthopedic literature, so this is a block from a retrospective chart review of popliteal blocks done. So this is only popliteal blocks, which we think are lower chance of nerve injury than your upper limb blocks. But here they had, and here they categorized any abnormal neuropathic symptoms, such as pain, numbness, tingling, more than 7 days, and they saw 5%, which is a lot more, and 0.7%. So it's not 0.7 per 10,000, right? So it's a lot, it's significantly more than what we report in the anesthetic literature. And then, I can skip that. I put too much literature to go into, except for really what I'm trying to get across is that I don't know who to trust. And actually, after my regional fellowship, I'm now doing a research fellowship, and I've discovered that most of the literature is not very worthwhile sometimes, and it's hard to know. And again, another literature review from Journal of Bone and Joint Surgery, looking at patients, and again, their complications. Look at the range from 0 to 60%, and long-term in 3%, which is way, way more than what we quote. And again, the studies that had the highest rates are the ones that directly asked the patients, do you have this symptom, do you have this symptom, do you have that symptom, and not just a chart review or an assessment or a referral. And I kind of am often uncomfortable because this is what I don't do, or very little. So it's going to the patients afterwards and seeing how they are. This is something else, the other entity that I was speaking about. It's the inflammatory entity. So first of all, in 2010 in Brain, which is a very highly respected journal, staff and others described 33 cases of post-surgical inflammatory neuropathy, none of whom had a peripheral nerve block, so it definitely can't be related to the block. And some of them were in the distribution of the surgery, and some of them were not, in completely unrelated nerves. And this entity was described as acute motor deficits and pain, sometimes after a symptom-free period. And these were patients that, if you treated early with high-dose steroids, you actually improved the outcomes. So I spoke with a Dr. Peter Silbert, which I think probably a lot of the more experienced regionalists know. He's a neurologist in Perth who a lot of the cases are referred to him for neuropraxias and neurologic dysfunctions after surgery and blocks. And he says that in his practice, first of all, it's always a referral by the surgeon, and most of the time, or some of the time, the anesthetist doesn't even know. And most of the time, the neuropathy is in the distribution of the peripheral nerve block. But is it something that the anesthetist did? We can't, if you want to, you can blame the anesthetist. But really what he thinks it is, it's a propensity that the patient had. And for this, and it looks a lot like Parsonage-Turner syndrome, which is the inflammatory neuropathy of the brachial plexus, oftentimes, which is completely unrelated to blocks or surgery, even though it can be caused by that. And again, the important thing that he was saying is that if these patients are seen early, then their recovery can be changed, it can be improved, versus the other patients where if we've injured their nerve, we've injured their nerve and hopefully their nerve will recover, but in this case, it's actually something that needs treatment. And it's not so uncommon. He doesn't have a denominator of the blocks, but he has all the referrals of all the people who have suffered this, and it's not an insignificant amount. And classically, it's either the people who have pain and motor weakness after a symptom-free period, or he says the other way that it sometimes shows up is the blocks kind of not wearing off in time. Like after 2 or 3 days, the patient still has some numbness, and then it turns into pain. So those are the patients that we need to be wary of, but we're not seeing them again. And then this was just an interesting thing, very new article in Regional Anesthesia and Pain Medicine. These people did cadaveric studies of intraneural injections, and then they looked in the microscope and they saw no fascicular injury, no intravesicular injury at all, and they're saying that, maybe it's fine to inject intraneural. Who knows? Is the study any good? I don't know. Most studies are not good, I know that. And then really this was the guidelines. There's the WASORA practice guidelines, and then after this there's the UK guidelines of really what to do if someone has neurological symptoms after a peripheral nerve block. So if they have that after, so it's not going to be neuraxial. It's going to be here, and again, if it's limited to unilateral common site of compression, that yes, then they say just observe. But always I say, again, some of the patients we need to not just observe, but we need to send them to a neurologist quite early. See that there's not any surgical issues. If it's only mild, we can observe. If it's not just mild, we should consider a neurology consult. And then nerve conduction studies. And this is like the important bit here, consider the postoperative inflammatory neuropathy with expedited workup, because those are the patients that we can help. And the UK guidelines are also fairly similar for peripheral nerve block is if we suspect dysfunction, then we need to look at the pre-op deficits, and then if it's new onset neurological deficits or the block is lasting longer, then we should do a neurological review. And if it's urgently, if it's painful or if there's motor symptoms. So basically, after all this, really for the past 6 months, I've been spending so much time looking at all the literature, and I think that the post-operative transient neuropathies are much more common than we think. That perhaps ultrasound has increased the safety, although no one's shown that. But really, there's a lot more peripheral nerve blocks performed nowadays. It used to be the sphere of just a few people, and nowadays every anesthetist is expected to finish training being able to do some basic blocks. And we need to stop throwing the blame at the surgeons, and the surgeons need to stop throwing the blame at us. And like I said, not all the nerve injuries are block related, but some of them are, probably more than we think. And the key thing is that there's that entity of inflammatory neuritis that is in the distribution of the block. Early treatment of that can improve outcomes. And then the question is, there more room for follow-up by anesthetists, more space for audits? I think one of the most interesting things is that the National Audit Program, the next NAP, I think it's 8, they're planning on doing on regional anesthesia, on peripheral nerve blockade, and at the suggestion of one of the consultants at Royal Perth, I actually wrote to the person who is heading this, and I offered to participate along with them. But I was very politely declined. But we thought it could be kind of neat to see how it is on an international level, and to have a big database again to show us the denominators. And if we don't know the denominators and we don't ask the patients directly, then we won't know the true incidence. I still don't know what the true incidence is. That's all. And that's all my references. Thanks.
Thank you, Anat. When in doubt, just blame the surgeons, I think. Our final speaker is Dr. Alex Wycherley.
Hello.
Welcome. Alex generously agreed to give his second talk at the Journal Club. He's a consultant anaesthetist at Fish with a keen interest in regional anaesthesia. And there you are. And also runs the Airway Rescue course wet lab at Murdoch University. Alex will be speaking about the Fish new quality improvement project called Prep Check.
Prep Check. Yeah.
Welcome, Alex.
Thank you.
Thanks.
Hello, everyone. Thank you very much for listening to me. I'm going to be talking about Prep Check, which is a new initiative that we're driving from Fiona Stanley and a few other hospitals. It'll be rolling out soon as part of a big trial. We're quite excited about this, but a few declarations first. I've never knowingly done a wrong-sided block, and this is what we're talking about today, but I haven't done one yet. It's very possible that we could all have one in our careers, given the incidence of these and how keen we are on regional. And we're all human, and we all make human errors at some point. And secondly, this is all work in progress still. So I'm very keen for genuine feedback, a critique of this process, and of the idea in itself. Prep Check, new pre-block timeout. So just to sort of clarify, pre-block timeout is the process similar to stop before you block for checking that you're not going to block the wrong side. How do I do this? Okay, so wrong-sided blocks. So the incidence quoted variably in the literature about 1 in 6,000 to 8,000. The problem is it's quite obvious that stop before you block has not worked. And that's been admitted by the original authors of it. Implications of wrong-sided blocks, unnecessary subsequent blocks and risks, need to do a secondary block for analgesia. If you've blocked the wrong side, suboptimal analgesia, the risk of cancelling a patient, delayed discharge, etc. And there is this talk of the risk then of a wrong-sided block progressing to what is clearly much worse, wrong-sided surgery, although I'm not actually aware of that happening in the literature. But the bigger implication, I think, for anyone who's been involved directly or indirectly is the second victim syndrome. The loss of confidence, the stress involved for all the staff involved. In the UK, it's called a never event in the NHS, and in WA Health, it's a SAC1 incident, which requires investigation. And overall, it's not a very good marker of quality of an anaesthetic service. And Avant agree with that, and they feel that it's an indefensible claim, being the largest MDO, and that because it is a preventable medical error. Risk factors, you probably know all of this already. Time delay between doing the WHO check and performance of the block. Position changes, because you may have checked one position and moved the patient. Lack of a visible surgical mark. Drapes, dark rooms for ultrasound, etc. Bilateral pathologies, happens to us a lot doing hands. Lack of a block timeout being done. And then the human factors things. And I'm sure you'll agree that most hospitals have these human factors things, and they will likely get worse as we all get busier with a sicker population. So you probably do some kind of a stop moment, like based on the Stop Before You Block campaign, which started in the UK in 2010. That was initiated from Nottingham Hospital Group after they had 5 wrong-sided nerve blocks over a 12-month period. In all 5 of those cases, the surgical mark and WHO sign-in were correct. They identified several key factors: distractions in the anaesthetic room, time delay between the check and the block, covering the surgical mark, as we've noted before. And their campaign was aiming to reduce further incidents and raising awareness. Picked up by ANSCA, who in their 2014, which is the most recent guidelines on management of major regional anaesthesia, i.e. any peripheral nerve block we would do that's not just superficial local, they say that a block timeout should be performed with verification of the site inside, with another clinician, identification of the patient, surgical consent, surgical mark, discussion with the patient if possible. Interestingly enough, they recommended in these guidelines placement of an anaesthetic mark and a pause prior to needle insertion to verify the presence of the anaesthetic mark. And they provide a lot of resources as well for that. Myself and Sam Wong, who's in the audience, introduced a cross-site Stop Before You Block process at Fiona Stanley and Fremantle in 2016, based very much so on the UK one, and there was an active decision that we would not include the use of an anaesthetic mark to block where you're going to do the mark, and that's going to come up a bit later on. So that went fine for a few years, and then unfortunately 2019 to 21, over an 18-month period, we had 3 wrong-sided nerve blocks: a femoral, an adductor canal, a subtenon in a NOF, an elective knee, and an eye. So I was involved in the safety and quality review of that, and then we looked at those cases and felt that we already had a robust policy in place, Stop Before You Block. We hadn't been promoting it for a while, so we decided to have an education drive, replace the posters that had fallen off the wall, consider Mock Before You Block, which had been published recently, and then also include a new Stop Before You Block tick box on the anaesthetic chart. Unfortunately, that didn't really work in the long term, so we had another 2 wrong-sided blocks then, and that's our 5 cases similar to Nottingham then, and we felt we needed to have a look at the whole process. Interestingly, in all of those cases, the correct side was then blocked afterwards, subsequently, and then surgery, so the patients had both sides blocked in the end, surgery commenced and there were no other complications other than the fact that patients had inappropriate blocks on the wrong side. So at the safety and quality review we had later, after those 5 events, we decided to take this topic a bit more seriously and look at it in a bit more detail. So that involved a review of all 5 cases to have a look at any trends or themes, issues with the process, an audit of our own department of quite a number. We have about 150 to 160 anaesthetists, including registrars, a literature review of just the key publications and what had come out of the UK more recently about Stop Before You Block, and then also just review the whole process itself. And specifically from a human factors viewpoint, because there was a bit of interest, and Adam mentioned about my involvement in the previous Murdoch Pig Lab stuff. That was there's a lot of human factors overlap there as well, which is we've helped to bring in. So looking at the 5 cases in total, common risk factors that we're aware of: unfamiliar lists, blocks, junior or less experienced staff doing regional blocks the first time, staff changeover, stop before you blocks not being done, repositioning. These things happened in those cases. But other insights: wrong-sided blocks in awake patients. So one of the eye patients was awake, so that's not necessarily foolproof in terms of preventing, because patients may just quite happily let you block the wrong side because they trust you so much. Wrong side being prepped. So this was an interesting thing. Where we had data, it was evident that the wrong side was prepped before the wrong side being blocked. So the error being made at the time of prep. The education and training that we had done after the 3 cases hadn't worked. So clearly something else had to be done, and perhaps stop before you block, or that it's not being done, and perhaps there's a reason for that. So this is I went to a leadership management course. This was a hierarchy of interventional effectiveness that they showed us at this meeting from this Patient Safe Group website. Here is a sort of less effective versus more effective interventions in terms of how effective they are in the medical workplace. This is essentially what we'd done. Tried to improve the education training and raise awareness, but what we felt we probably had to look into this part more, and I think that's going to, we've tried to basically focus on these 2 things: improving the process, trying to create a forcing function, and simplifying the process as well. So we did an audit of a departmental audit. 21% of our anaesthetists had actually been involved in a wrong-sided block. The major barriers they felt to performing a block: simply forgetting, time pressures and distractions, and cognitive overload. What reminds you to perform a stop before you block? Personal behaviours, anaesthetic tech prompting, visual aids. And what process or systems could be put in place to reduce the incidence of wrong-sided blocks? Joint responsibility from theatre staff, visual aids, stop before you block stickers. Okay, looking at the literature, this is a very brief just sort of discussion of some of the key papers in this area. So we mentioned mock before you block, and this raises a few interesting questions from the human factors side of things. This is from an editorial in 2016. This editorial accepted that stop before you block had probably failed. This is only 6 years after it had been implemented. Additional checklists had not reduced the incidence. They talked about the human factors of a block placement, calling block and putting in a block a largely subconscious single confluent event with a fixed purpose. The purpose of learning to create a single fluid movement, the process itself rarely offering a natural break to facilitate a stop, and the commitment to action being the psychological point of no return. And their proposed solution to that was this mock before you block process. Now, I don't know if anyone has actually used this in practice or uses this now, whereby the anaesthetist prepares an additional empty syringe or needle sheath, pretends to perform the block, discussing with the assistant that this is the mock block, and then only then would they use the second syringe or needle containing to use the block. The aims of the mock block being that it serves as an action trigger rather than a verbal trigger, aiming to recouple the action identification perception of a block. That's a lot of psychological chat for trying to create some kind of a physical prompt or a forcing function to try and remind someone to do the stop moment. There was some criticism of this in the literature as well. This is quite a good paper, a letter I saw, which raised some of the other human factors points. Human factors research warns that the more arduous a process, the more likely human operators will willfully cut corners. Practitioners seemingly do not like to interrupt the flow of a block's performance. Prevailing pressures on productivity represent obstacles to the real-world adoption. And a stop procedure for nerve blocks must be carefully designed to ensure maximum adoption and usability in clinical practice. Now, I think that's all pretty sound advice, and but then a few years ago, the original Stop Before You Block authors proposed an update called Prep Stop Block. Now, I don't know if any of you have been aware or used this process, and I'd be interested to get some feedback on this. So this is a new process, an adaptation of the original Stop Before You Block. They admitted again in their editorial, stop before you block has not worked. They identified issues such as local flexibility. They mentioned the fact that additional anaesthetic marks can actually lead to wrong-sided blocks. Mentioned again about the stop moment being done at the wrong time, and raised the issue of multiple nodes at different sites, but an assumption that only one stop needed to be done. Their new process, Prep Stop Block, was aiming to standardise practice across all UK hospitals, deconstructing the act of block performance and creating a clear interruption with the stop moment. The Safety Anaesthesia Liaison Group and the RA UK have actually fully endorsed this in the UK, with the chair of the working group saying that we're pleased that the SOP will now be applied nationally. Stop moment as a two-person process that happens only after preparation is complete and thus immediately before needle insertion. Ensuring that this is applied in a consistent way across all trusts makes patient care safer. So in the UK, there's a drive to do this new process in all hospitals, and they're standardising the process. The issue that we had with this is that there was a lot of concern about this process, so I'm interested to see what people's thoughts are on this. So how this works, Prep Stop Block, this is a new UK process. Prep, initially the patient is prepared for the block needle is put then in a tray. The blocker then hands that tray to an assistant, therefore preventing them from doing a block. Now this is the forcing function that they're trying to introduce here. Then you do the stop, which is that you do this stop just before the block. You verbalise to your assistant, I've completed my prep, let's stop before you block. Assistant says, okay, let's stop before you block. Both then check the mark and consent check with the patient. And only then does the assistant pass that back to the blocker, who can then complete the block. And the recommendation is that any delay then requires a restart going back to the preparation stage. We had a look at this process, and frankly, we didn't think this was very usable in real life, and we had some concerns about this. And then we looked into this in a bit more detail from a human factors viewpoint, which led us to review our own process and the process of the stop before you block, the original stop before you block in general. One of the key components of the original stop before you block is this insistence that the needle in hand moment is when you do the block. So it's preparing everything till the very last minute and then placing the needle into, to do the block, just, doing that check moment just as you've got the needle. So this is what they call immediately before the block, or needle in hand. The idea being that you're then preventing the check being done, say at the WHO checklist, and then you blocking the wrong side subsequently because of distractions, etc. But if you think about the order of events, this is what normally happens for doing a block. You've done your consent, you're marking everything out, you're monitoring, etc. You set the patient up. Then anaesthetist positions themselves next to a patient. You then position the ultrasound machine, the block trolley next to you. You expose the patient. You apply sterile skin prep. You start to ultrasound scan the patient, and then you finally do your block. It's at this very last moment that the original stop before you block, our own process based on stop before you block, and even more so the new stop before you block, prep stop block process, it's at this point that you're expected to do the stop moment and check that you're actually blocking the correct side. The issue with this is that if you've identified the wrong side, all of these steps imply laterality. It leads you to be mentally and physically primed to do a wrong-sided block. Now, there's a few issues from that from a human factors viewpoint. So this needle in hand rule was originally introduced, as mentioned, included in the original stop before you block to avoid time delays between the check and the block. They specifically mention a case of a patient who had a WHO check-in, they did a check for which side, and then they had a very difficult spinal, and then they blocked the wrong side. That was from the original Nottingham work. The aim being to avoid correctly identifying it but then blocking the wrong side. It's become a central concept of their new updated prep stop block. And there are a few issues with that from a human factors viewpoint, which we've identified now, which might explain why stop before you block has not worked. So number one, confirmation bias. Waiting until immediately before needle insertion delays the check until the middle of the block process, and it allows for the potential for the wrong side to be assigned from the start and throughout the process. If you start on the wrong side, you then create a compounding error, i.e. a slippery slope, forcing the user to go before you know. You've already gone through the process until the last minute, and the check then is at the last minute with needle in hand. Secondly, it's at that point that the check's done, but that is actually a time of maximal cognitive load. When you have needle in hand, it requires a break in concentration during the flow of your block. It usually occurs after ultrasound scanning, and as you know, some ultrasounds can be very tricky, and we become very focused on the ultrasound, and the next thing we want to do is get that needle right next to the nerves, because we've formed that perfect 3D image in our mind of where we want to put the needle. And task fixation, therefore, may explain why the team then become easily distracted and don't do the check. It disrupts workflow, and as I've mentioned from the previous human factors letter, human factors research suggests that the more arduous a process, the more likely operators are willing to cut corners. And I suspect this is happening quite a lot. I imagine that anaesthetists wanting to just get the block done, they've got the perfect image, they just want to stick the needle in, may not be doing the stop moment at that point. It disrupts flow, which makes it more awkward for an anaesthetist. And the concern with the new stop before you block process is that this tray handover thing, being quite clunky, it actually exaggerates that disruption and creates a bigger interruption to flow. I don't know if anyone else has noticed something about the actual poster itself, but it uses your typical traffic light red, amber, and green colours in the wrong order. So, as you know, and I'm hoping you'll notice this when you drive home tonight, it goes red, amber, green. Okay, but for some reason, and I have no idea, they've decided to flip that round. Okay, I mean, it's an interesting point, but this actually is contradictory to the natural intuition and you'll see the red, amber, red, yellow, green warning system used throughout medicine, throughout safety, as a typical kind of design kind of feature. And lastly, communication. What does needle in hand mean? We couldn't actually agree on that within our department. Is it when I first set up my equipment? Is it immediately just as I'm putting the needle in to put the local in? When is before? Stop before you block? Well, the WHO checklist is before a block. It's not necessarily, this term, not necessarily understood by the wider perioperative team. We do need to include nursing staff in the wider theatre team, especially for getting the surgical consent. So what did we do about it? We did a mini Delphi process within our department. We used, all of the regional anaesthetists who have an interest joined onto a Teams group, and we discussed doing an iterative process, going back and forth, discussing how we could change the process. The initial idea was called team prep. Now this is where we tried to create a forcing function. Therefore we thought, well, let's have the assistant have to do the prep. That means that the anaesthetist, they can't do a block until that's been done, But then some issues were raised about that because, yes, fair enough, you're then potentially sharing the responsibility with somebody else for perhaps blocking the wrong side if the wrong side is prepped. So we decided to scrap that whole team prep idea, and that eventually evolved to what we call prep check. So it's as the team prep idea being, but it's a bit more simplified. So basically the blocking anaesthetist maintains responsibility and applies the prep for themselves. But the key change to stop before you block is that the pre-block timeout, or the block check, is done at the time that skin prep is put in. Now that's a very simple, seemingly simple change, but our thoughts and hopes are that that simple change can improve things from a human factors viewpoint. So this is a new process developed at Fiona Stanley, informed by the Safety and Quality Review, Departmental Audit, and the Process Review, making human factors a core consideration. We feel it's a human factors problem that should have a human factors answer, designed to be quicker, easier, more logical, so that people hopefully will be more engaging and more compliant with it and keen to actually, undertake this process. And it's so far at Fiona Stanley, it's actually gained a lot of traction, and it's gone down very well with the techs, for instance, and the theatre staff. The key change being, as I said, the check is done at skin prep for the block. But the other aspects in terms of checking with an assistant, the three things that you check, i.e. the patient if they're awake, the patient ID band is the gold standard for checking the patient, surgical consent, surgical mark. Those are still the three core things. And you do it with an assistant, i.e. a tech, or anyone else, but it's communicating that with another member of the perioperative team. And once prepped, the idea being that it's actually quite unlikely that the anaesthetist will block somewhere else. And that, I'd be interested to see what people's views are on that. And that's one of the arguments behind this, is that, you know, once the anaesthetist has prepared an area, the idea that they would then willingly put a needle somewhere they didn't already know to be sterile, regardless of whether there's dye in there, it's perhaps unlikely that they would do that without questioning whether that site is sterile, i.e. do they need to apply PrEP again. So where do we think this improves on human factors? Well, it avoids the confirmation bias from prepping the wrong side, because the check is done at the start of the whole block process. So you know you're on the correct side from the start, therefore preventing it from taking place in the first place. And as we know from our safety and quality review, where we had data on those blocks, they were all prepped on the wrong side. So perhaps that's where those errors are coming from. Reduces cognitive load because the check's done at a time of less stress, i.e. not when you're just about to put the needle in and you've got this 3D image in your brain and you just want to put the needle exactly where all those nerves are. So once it's done, you can task focus on doing the block. So it's less distractions then. Hopefully that then improves workflow, causing no interruption to that block at that key moment, hopefully preventing unnecessary re-prep then, because if you have actually done the, stop before you block, the original one, properly, on a wrongly prepared limb, you've actually wasted that time anyway. So although it stopped a wrong-sided block, you've actually wasted a bit of time to go back again. We hope it will be quite intuitive. It's an action. We're linking an action of prep. So hopefully changing the behavior in anaesthetists so that they'll think, right, when I'm putting a prep on, this is actually the committal point, the point of no return in terms of we're going to prep this side, we're going to block this side. And hopefully then that becomes the action trigger that the mock before you block was hoping to do. The application of the skin prep is the physical act. And then linking prep with check. Right, I need to do a check. Okay. And then eventually changing behavior anaesthesis, that just becomes an automatic thing that you say, let's do a prep check with a stick in your hand. And then hopefully improving communication. Prep, check being, they are terms that are well known in the theatre environment. The application of that skin prep is an obvious visual and verbal clue for everyone around you in that area. Hopefully then acting as a surrogate block mark that ANSCOR were originally suggesting that we use. But again, I'd argue that the presence of the area being sterile is something that the anaesthetist should be aware of, whether there's dye in that or not. If you don't know that that's sterile because you've blocked it, or because you've prepped it, then you probably won't be putting a block needle in it. So we did a little pilot trial at Fiona Stanley between May and July. Thank the regional fellows, a few of them are here, ex-regional fellows. And led by these guys and myself. We wanted to real-world testing. So we actually just targeted specific theatres, specific anaesthetists we knew would be doing blocks. We just asked them to follow the process. We gave them education, give this and do a little team survey at the end. 54 responses, mostly consultants. Prep check used formally 48 times during this survey. Those individuals had predominantly used stop before you block, mostly. A couple had used the new prep stop block. Over 90% felt the new process was easy to understand, easy to communicate, and even over 50% believes it saves time versus existing processes. Over 3/4 felt it was an improvement on existing processes. Over 85% did not encounter any barriers to this, and those barriers were things that you would expect in a small pilot study. Lack of training, confusion with the current process, lack of nursing staff. We hadn't updated the nursing staff about this specifically until we wanted to do that when we trialed it, and the fact you might still forget to do this. What they liked about it, all the things we're aiming for, simple, intuitive, logical, etc., etc. Are you likely to adopt it? Over 90% agreeing or strongly agreeing that they would be likely to adopt this as their new process, i.e. their new pre-block timeout. So the plan now is that we're going to be rolling this out over a number of hospitals in Perth. I've been very lucky to have a lot of engagement from some regional leads in other hospitals. Chris Mitchell, Joel Krause at Charlie's, Bjorn Paganetti at Rockingham, Laura Prates at Royal Perth, Shane Power at Midland. And I've been in discussion now finally with Perth Children's Hospital because they do the blocks. And if anyone else is interested in this process and would like to be part of that trial, then, or at least trial this at their institution, then please let me know. Presenting here, planning to hopefully present at one of the WASORA meetings, either the next year or the year after, once we've finalised some of these details and gotten the trial data. And now we're currently working on things like a branding, trying to create this into some kind of cognitive aid style, to have a poster, a logo, a video to associate this as well. And this is all work in progress. If anyone's giving me feedback about now or after, I'll be keen to. But this is kind of how it's going to look. It's going to be like very simple, very eye-catching. Step one, prep in hand. That's where it starts. Let's do a prep check. I'm telling my assistant, let's do a prep check. Step two, we'll do the block check. And that is checking those three things. And then step three, prepping the site. Okay. And then that then being free to do the block. By ordering it in that 1, 2, 3 thing, it actually keeps that check specifically within the process of prep. So it's not prep before you stop, it's not stop before you prep or anything like this before that. The word before can mean anything, so it's just prep check. If anyone's got a better name, then let me know. But it's kind of trying to make it very clear then when it's being done, when that check should be done. And I think this process is probably the way to kind of ensure that. And that's it. That's the process. So I'll be very keen to take questions or get some feedback. And this is some of the things. This is what this is my PowerPoint-esque attempt, and this is a much more professional attempt by our graphic designers. But this all work in progress at the moment. So anyway, thank you very much for your time. All right, cheers. Cool. I think we'll, thanks very much for that, Alex. I'm sure there'll be many questions. I think we'll invite the speakers back up onto stage and have time for some questions now. Hopefully we have a couple of roaming microphones, and we'll leave a couple up over here. If Chris is here with a couple of microphones, it's around somewhere. No, anyway, well, maybe we'll just... couple of microphones. Any questions? Shane, I'll just...
Hi guys, thanks a million. Some great speakers tonight. Ed, I was just wondering about your own practice with gastric ultrasound and whether you've kind of have a routine now with GLP-1 agonists on your lists, say for elective surgeries. Are you tending to scan them routinely if it hasn't been held or has been held, or have you kind of made a plan with that?
I think it's useful where you've got like clinical equipoise, you're 50-50. So if they're, like I had someone the other day who was 130 kilos, so the Ozempic wasn't quite working yet, but for that person, they're going to get a tube, right? And it's whether you do an RSI or a standard sequence induction. And for them, I'd scan them. If the antrim's empty, I'll just do a standard sequence induction. So I do use it, but if I'm fairly sure I'm going to intubate someone, I just intubate them. If I think I'm going to use an LMA, I'm just going to use an LMA. But where I'm not sure, I do scan them, and it's quick and it's easy, and it's so yeah. If they're on Ozempic, I generally do scan them, unless I'm definitely going to do an RSI. Yeah.
And just quickly, how long do you think it takes? Now that you're up to speed.
Pretty much once you get the probe in just above below the xiphisternum, it takes, honestly, you can see, once you see the antrum, it's like seconds. Yeah. Yeah. Sometimes it takes a little bit more, but not much. Yeah.
Great. Yeah. Thanks a lot.
Yeah. No worries.
Questions? Brian.
This is for Ed, and actually another little plug for the ANZCA guidelines. You'll probably notice that two things that are coming out. One is going to be coming out in another 2 weeks, and one which we just put on the website. The first one which we just put on the website was a point of care ultrasound document, which is in pilot version at the moment, because there's a lot of point of care ultrasound happening in lots of different things, pleura, gastric ultrasound, etc. It's been decided that we need to put some quality markers around that in credentialing, people being credentialed to do these, and what's going to take to be credentialed, and what kind of CPD is required to maintain that credentialing. So that's something that'll be worthwhile looking at. Gastric ultrasound is easy to do, and the numbers to get credentialed are small, and the numbers to maintain your credentialing are small. But for example, transthoracic echo is much more complex and much more difficult to get credentialed and maintain credentialing. So that's one thing which I would advise you to look at. And the second thing which will come out in a couple of weeks is that original document that ANZCA signed on to with the Diabetes and Obesity Associations of Australia, with the gastroenterologists, with regard to advice around how to manage patients who are taking GLP-1 agonists. That underwent its review today, that document, and the new version of that will be on the website in a couple of weeks. Suffice to say that gastric ultrasounding gets more of a limelight in that new document. Except we have no science around any of the guidance yet.
I think it's a skill that doesn't take a week-long course to do. I think an online course and just get stuck in, it's really straightforward to do. But I think it'd be great to have some sort of official online course and some credentialing, or some sort of mini exam that you could get some more authority around it would be really welcome. I think one of the things in practice I found is that it's so quick and so easy to get information that can adjust your anaesthetic management. It's hard not to do it when you do it, because you can see the antrum, and it gives you information that influences your decision.
Mitch.
Well, thank you very much for 3 great presentations. Alex, just on your prep check, I think it's such a great initiative, and I know there's been more than a few at Charlie's over the years, so it's all around the place. Just one thing I note is in my own practice, I think my greatest saviour is my tech saying to me, let's do a prep check, not me remembering to do a prep check. And I just, have you thought about that in your posters? Because it's definitely throwing the responsibility fully on the anaesthetist to say, let's do a prep check. And have you thought about opening it up as a team? It could be anyone in the team saying, let's do the prep check.
Yeah, I agree. I just had a list this week where my tech reminded me to do a second prep check for a second block on the same leg. And she said she felt much more empowered because it was a much clearer process for them to follow, and providing the prep, for instance, is something that they would do as part of a normal block assistance. I'm also just anecdotally finding myself, as I'm doing prep check, that's then now becoming a lot more well known within the theatre environment, and me just saying, let's do a prep check. In theatre, then a nurse comes from behind and presents the consent, which would have otherwise involved myself or the tech having to go and find it from somewhere. So this is where I think if we're just improving the language around this topic, it's raising the awareness of it, and these are all concepts that are well known in nursing as well. But if we can engage the nursing staff as best as we can in this whole thing, I think that's going to really help us, as you said, to save us from our own errors. Yeah.
I hope you won't ask
No, you
yourself
can't.
a question, Ed.
Yeah.
Yeah, I'll agree with it myself. It's just that Alex, I worked with Nat Haslam a fair bit in Sunderland, and he was one of the architects of Prep Stop Block. Just prior to him publishing that, he was going to say that we did about 2,000 blocks and never had a wrong-sided block, and this is the system that we use. But interestingly, it was like a day or two before he was going to publish that, they had a wrong-sided block in Sunderland, and obviously he was gutted. But what it was, the wrong-sided block was actually an ESP block, where the midline is, and the side is so close. And that was my little story. But just for the prep check, when you do like a paravertebral ESP, I don't know about you, but when you prep, you inevitably prep both sides, and that's just perhaps something to watch out for. Or have you got any? Would you just prep one side or different colours? I don't know. Yeah.
Different coloured prep. No, that's an interesting idea. I think that's a very difficult thing to manage generally. There's, ambiguity of laterality in the prepping process, during the whole of the process up until the point of actually putting the needle in. And I think there are some potential other issues with prep checks, such as are there any blocks that do not require prep? Such as I don't do eye anaesthesia very often at all, actually. But for instance, subconjunctival blocks, I think some of my colleagues may not use any prep at all, but they'll certainly put eye drops in, so you could sort of call that prep. Talking about the ESP issue, I think this is part of there is clearly an issue with peripheral nerve blocks being blocks on the wrong side, and the audit that we did demonstrated that the preparation being applied to the wrong side is one of the big drivers for that. I'd be quite keen to know some more details about that case and how that could have been prevented by any stop process, whether it was a stop before you block, whether it was this process itself. If you're having to prepare the whole back, then there is always the risk up until putting the needle in. You're right. Perhaps that then is the correct time to do the stop moment. I'm not sure. This is all work in progress. So the reason we're here today is to try and sort of brainstorm these kind of, unusual scenarios, because we're quite keen to have a robust process for as many blocks as possible. Yeah. Thanks.
Hi, thanks everyone. They were great talks. Look, just regarding the ESP and the side, I think the prep doesn't have to be just you physically only prepped the exact part that you're putting the needle in. I guess it's still just a marker to think my whole setup, where have I put the ultrasound, how have I got the patient positioned, and I very much like what you're doing, because it's, having done one wrong-sided block in my life, it was very much that it all started with the ultrasound had kind of been put on the other side of the patient, and I thought I'd put it there, but it hadn't. It just happened to be lined up on the wrong side of the patient, almost in the exact alignment that I would have put it if I was doing the other side. And everything flowed on from that. Yeah. There was a lot of other human factors like, time pressure and stuff. But it all started from the very early process. And I agree that if you're leaving your check right until the very end, you've gone down this whole cognitive process right from the very start and convinced yourself that things are right. And so doing something at the very early part, and obviously the prepping is one of the very first things that you do, to just think about, is this the right side? Have I got everything? Am I standing on the right side? Am I standing where I want to stand? Have I got the ergonomics right? And those things will all stop you doing the right thing. So even if you actually have to prep both sides of the patient, if that's still your cognitive clue to sort of think about your entire setup, it should still go a good way to try and prevent you sticking the needle on the wrong side of the patient.
Yeah, I think you're right. I think that's certainly what we picked up. And thanks for sharing your story. And I very narrowly prevented one of our regional fellows doing a wrong-sided ESP because he had seen the patient, shook their hand, right, we're going to block that side, flipped the patient round the other side, and went for the opposite side, which was the same side as they were looking. So that's a position change area again. But you're right. by introducing the check at the time that you're going to prepare, it's essentially creating we're trying to create that forcing function, linking it to an action at the very start of the block process. Now, you can argue when the start of the block process occurs. Does it occur? Yeah, you're right. It does occur when you actually stand next to the patient to prepare your equipment. It may even start when you put a cannula in a patient. Like I've spoken previously about, a wake hand surgery that we do at Fremantle Hospital. And we've been very lucky, touch wood, that we've not had a wrong-sided block in hands, and we do nearly 1,000 blocks a year. And I think one of the reasons for that is that we have to put a drip in, and we have to put a drip in the opposite hand. And then we then know to put the drip on that side near the wall, because we have to block with the side of the anaesthetic room to give us space. So we're already starting to think about laterality. And it's when we go into our normal just right block mode, without that thinking about laterality, I think that's the greatest risk, is when you just go through the motions of doing a block. And then the implied laterality of just your position and their position takes over, and then it's the slippery slope, the confirmation bias happens. So then there should really be a discussion with someone else and a consideration of laterality at the beginning of the process, which is what we're trying to do with Prep Check. Thanks.
I've got a question for Anat. When you spoke to Peter Silbert, did he talk about sort of a specific protocol, like how much, like the dose of the steroid, the duration of the steroid, and how long it took for the inflammatory neuritis to recover after the steroids were started?
So he spoke about titrating the steroid therapy to the pain. So you have to stop treating, because the patients were being incorrectly treated with opiates for their pain, which was of an inflammatory nature, and he titrated the steroids up until the pain subsided into what you would expect for normal post-surgical pain, and then he continued on, and then they would try and titrate down, and if the pain increased again, then they went back up. It's very much a titrating. The pain is the sign, is the marker for the inflammation. And it's also the inflammation is doing the damage. So that's what you spoke about.
Use like prednisolone or?
Yeah, prednisolone normally, yeah.
Any other questions? One more from Brian.
Peter Silbert's interest in regional anaesthesia complications came not just because he was a neurologist, but because his eldest brother, Brendan, is one of Australia's most experienced regional anaesthetists in Melbourne. And so that's why he initially got interested in this. The database, the Aurora database, that was the Australian database, was from one of those things where you had said, I'm not really sure why that stopped. It stopped because the incidence of neural complications was so low that after the first 100,000 blocks, we couldn't justify continuing the database with the requirements which are for patient data safety around it. Why are we having a database when we're not finding anything, essentially? And then Barrington moved back to the US. So that's why that database got stopped, was because it wasn't being able to really detect the things that it was trying to detect. The incidence of neuritis or inflammatory neuritis after regional anaesthesia is about 14%. And the incidence of inflammatory neuritis after general anaesthesia with no block is about 14%.
Yeah, the original case series that was published in 2010 was 33 cases that none of them had a peripheral nerve block done. But if you talk to Peter Silbert, he has dozens of patients who have been referred to him who have this inflammatory neuritis in the distribution of the blocked nerve. So, and again, if you're saying, again, going back to the database, that it didn't find enough cases of nerve injury, I guess my question is, well, how are we looking for that nerve injury? Were we just waiting for a referral, or were we actively contacting? I mean, it would be obscenely hard to actively contact every
for the patients
patient.
to be included, they had to have active questioning. So for any of the patients who were in the Aurora database, had to be off questioning that was done within the first 2 weeks, so that they could go and get nerve conduction studies done within 4 weeks. So that's how the data set was set up.
Yeah, so I think that it's very hard I think today there's probably a lot more peripheral nerve blocks being done than back then. It's almost, well, I don't know if it's impossible. It's difficult to contact every single one of those patients and ask them these directed questions. Yeah. But again, it was just so interesting to see the differences in the literature when a patient is directly contacted versus when they are not. And because patients often don't know, because after surgery things hurt and things feel different, and so I'm pretty sure we're missing quite a lot. I mean, is that a terrible thing if most of it just, recovers by themselves? I don't know.
Yeah.
Question from Sam.
I'm Sam, I'm the regional lead. At least intermittently. I think it is actually possible to ask every patient these questions, and one of the things I want to do is actually have a questionnaire sent to every patient. The only way you're ever going to capture this data and pick up complications in a timely manner is to do it prospectively, not just at an intermittent audit nature, like let's audit patients for 1 week, 1 month, 3 months, 6 months, a year, as the RCA guys are planning to do and have done in the past. You've got to capture it continuously, and you could probably do this with an electronic database. We've had set up a similar process for the hand surgical patients at Fremantle. It's I don't think it's ideal in terms of capturing all the complications, but each patient is sent a questionnaire by text message or email for them to respond and say, do you have any ongoing complications, for us to then work out who needs to be seen.
Obviously, when I first started as a consultant at Royal Perth, I used to share an office with the research nurse. In that stage at Charlie's, we didn't do a lot of real research. The research nurse was almost entirely spent her entire time calling patients who'd had regional blocks. And the number of times I heard her over the phone saying, yes, I'm calling because you had a block. No, you did have a block. No, because you had surgery. You were in hospital. Patients couldn't remember that it had an operation, let alone work out whether it had anything. So if you want to add on to that they can use a computer or a mobile phone, you're still going to miss a lot of patients. And so I agree that the problem with these direct questioning is if someone has clear numbness, then that's one thing, but people are sore in the surgical field, and they're sore in the surgical field for quite a while afterwards, and having had a lot of people have a lot of pain, people's, working as a pain physician, people's description of what their pain is it tingling, is it numbness? People just say, oh yeah, it's tingling. And they've got clear musculoskeletal pain, but they're still convinced it's tingling. And so it's not as easy as just sort of questioning someone, and you can just talk to them and you can definitely find out whether they've got some sort of peripheral nerve injury, let alone whether it's related to the block. And so I think probably we do miss a lot of it, and as you say, a lot of it just gets better within a couple of weeks. But that's probably, you want to catch the ones which are not going to get better. And in my experience of having seen, a number of people have been referred to me who've, after they've had surgery and ongoing numbness and questioning about CRPS, the ones which have a decent motor block are the ones which are much more likely to persist. And I think they're the ones you want to catch, and they're the ones you want to make sure that you're seeing early to make sure there's not something reversible that can be done.
I've taken over that following up nerve injuries at Charlie's, and originally when Steve Watts at Charlie's started it, I think 2005 when we started our ultrasound, with this poor nurse who was employed to literally ring every single patient. It was originally done at day 2, and the problem was if you ring them at day 2, it's 10% of people have, if you really question them, have some touch of numbness here or there, and it created a huge amount of work, and then it was pushed back till 2 weeks, which made the collection a lot easier. And eventually, in I think 2016, we aborted it because really the time and energy of doing the survey wasn't worth it. What is worth it is if you find someone with injury, it doesn't matter what you think the cause of the injury is, whether it's the surgeon did it, it was part of their original trauma, or it might have been us that caused it, is to give them, put your energy in then and give them the time and attention, because at the end of the day, they're mostly humans, and the one thing they want is just to be actually respected that they've got an injury and some problems. And if you give them attention at that stage, even if they end up with some problem long term, they're normally pretty grateful of the system. Certainly the ones that I haven't had really any angry patients at the end of the process at Charlie's, even though there's been some disappointed people that they've got some symptoms. There's a few studies that have shown that if you look at the number of nerve injuries from surgery and the injury, and they had a motor car accident to begin with, was the reason they're having their surgery. If you try doing that when they've had no blocks or with blocks, it's within the same standard variable or standard error. So the number of injuries that we cause compared to the number of injuries happening is small. It's definitely there, but it's just in that random scatter area, which makes it hard for us to pick up and hard for our studies to be really effective. I think the number one thing is I give them attention when they do have the injury, and make sure you keep following them up, even if it's a pain in the ass, just to call them up regularly, because most of them just need reassurance. And what last thing that was, if they've got just sensory problems, I haven't seen anyone not recover. So, it takes a while and time, and some of those have been into the years, but if it's just sensory problems, I think they've all got to a case of recovering or at least being happy, and motor symptoms do keep seeming to improve with time, and it is more than a year, but most of the change is over a year, but it can certainly extend out a good amount of time than that. And if you know our mate Andy Travis, who's had his terrible leg injuries, he's years down the track, he's still getting a lot better. So there's a lot of neuro improvement happens over a long time. Thanks.
More questions? I think that will. Ed's got this question. Yourself again.
Very quick. The nerve injury. You showed the RAUK. Again, Nat Haslam produced that, and in his block room. So I used to be one of his fellows, and he'd make us phone every single patient up. It was the bane of our lives. It took a lot of resources, and we found nothing ever. But the problem we were like, the bandages were often on too tight, and people have paresthesia from cast too tight. So we were kind of like an orthopedic follow-up clinic, and it wasn't much fun. So.
I think it's almost 9 o'clock on a Thursday night. Thank you all for coming. Thank you. Please join me in thanking our speakers. Yes, we will see you all in May next year.